Thank you very much, Joan, and hello to everybody. Maybe I should say hola, ¿cómo estás? I speak a bit of Spanish because I am originally Italian, but yes, I've been working in Cambridge for the last 4 or 5 years. So thank you for joining us. In the next minutes, I'm going to give you a sort of overview about all the things that we can do with a transcranial Doppler, because I believe that transcranial Doppler is generally underestimated in our clinical practice, but at the end, it could really be a stethoscope for the brain. So let's start, unfortunately, with a bit of history. This is the boring part. So transcranial Doppler ultrasonography is a very old technique. It was first described in 1982 by Hazlitt, who was a neurologist. The reason why we use it so widely in our clinical practice is because it's very safe, it's really available, it's non-invasive, it's very reproducible, and it's used especially to evaluate the cerebral blood flow and the hemodynamics using the insonation of the basal cerebral arteries. So transcranial Doppler technique is based on the very famous Doppler effect. And here you have a picture of Christian Doppler, who is the guy who has found out what the Doppler effect is. What is the Doppler effect? It means that when a sound wave is emitted with a certain frequency, which strikes a moving object, that in our case are the red blood cells, which are moving in insonated vessels, the wave is then reflected with a different frequency, which is called the Doppler shift, here on the right upper. And the Doppler shift is directly proportional by the velocity of the object, and the received echoes can generate an electrical impulse in the ultrasound probe and then are processed to calculate the velocity of the flow of the brain. So these are physical principles. Let's try to be a bit more practical. We aim to insonate the Willis circle. This is the normal brain vascular anatomy. Unfortunately, in the clinical practice and in the reality, it's not that easy to find a perfect Willis circles, because in the 70% of the patients, there is an abnormality of the Willis circles. By the way, TCD is based on the insonation of these main vessels. The Willis circle is the anatomical structure, which is made by two compartments: an anterior compartment, which is made by the ICA, MCA, ACA, and ACOM-A, here, as you can see by the arrow, and the posterior compartment, which arises from the basilar artery, the vertebral artery below it, and the posterior cerebral arteries. So basically, what are the very basic physical principles? The ultrasound signals produced by a stationary transducer. What happens? If the object insonated is stationary, so if it's not moving, the frequency of the waves that are reflected as unchanged. But if the reflector is moving, what happens? It happens that if it is moving toward the transducer, the frequency increases, like in this case. But if a reflector is moving away from the transducer, the frequency decreases. So in the clinical practice, we have to think that when we put a probe on the brain of the patient, we are insonating a vessel, and according to the vessel that we are insonated, this vessel can have a flow which can go away or towards our probe. So very easily, what happens is that at the end, when the flow of the insonated vessels goes away from the probe, the color Doppler will show us a negative flow, which is generally shown as a blue color. And when the flow is towards the probe, the flow is positive and is shown as red as a color. So this is what we can see when we use the ultrasound. This is a very nice video. So the probe is basically here, and what we can see here is our Willis circle. And probably at a first look, it's not very straightforward, but if I show it to you like this, okay, with this picture above, you will actually realize, I will show you again just the movie, that this is the middle cerebral artery, okay, and this is the posterior circulation. But we are able actually to insonate and to differentiate the different vessels, not just because of the anatomy, but also because we know all the characteristics of the different vessels, and we are going through this point in a second. There is a problem with brain ultrasonography. The problem is that the brain is surrounded by the bone. So we need to find some windows. We need to find some places where the ultrasound can pass through and can insonate our vessels. In the clinical practice, there are mainly 4 windows that are generally used. So in the upper panel on the left, we have a submandibular window from which we can insonate basically the carotid artery. The most used window is the temporal window, which is in the upper panel on the right. And from here, we can insonate basically most of the Willis circle. We can insonate the middle cerebral artery, the posterior cerebral artery, and the anterior cerebral artery. And here, from the ophthalmic window, we can insonate the ophthalmic artery, and we can also insonate the optic nerve sheath diameter. Finally, the posterior circulation is generally found and insonated using the occipital window. And from here, with the patient in this position, we can easily insonate the vertebral arteries and the basilar arteries. But again, it's not just about the anatomy, because we know very well that there are criteria which will help us for the identification of the vessels. So basically, there are 2 types of transcranial Doppler. One which is based on the ultrasound, which is the one that we have just seen, which makes our life much easier because basically we can actually see the anatomy of the vessels. But sometimes we just have the blind transcranial Doppler. So we need to rely just on these criteria. So according to the cranial window which is used, the depth, the direction of the flow, the distance over which the vessel can be traced without branching, and the relations between the different vessels and the flow velocity, we are actually able to insonate in the 99% of the cases all of the vessels. This is a small summary of a vessel in the identification criteria. So as you can see, every vessel of a Willis circle has a different window for insonation, a different depth, a different direction of the flow, and a different velocity. So if we put the probe on the temporal window here, and we find a vessel whose flow is coming towards my probe, so it's a positive flow, and its velocity is between 46 to 88 centimeters per second, and it is at a depth of 50 millimeters. There is little doubt that this vessel is anything else but the middle cerebral artery, and so on with the different vessels. But also with a bit of training, we can also assess and differentiate the different vessels according to the waveform morphology. This is the typical morphology of the middle cerebral artery. As you can see, the posterior cerebral artery has got a flow which is slightly slower. Here is the bifurcation between the MCA and the ACA. And if you remember the anatomy and the slide that I showed you before, you will easily understand that the ACA has got a negative flow because it's going away from the probe, and the MCA has got a positive flow. So at the bifurcation, this is actually what we are going to see. And this is what we are going to see for each different vessel. I understand that at the first look could look a bit weird and a bit difficult, but in the clinical practice, after a training program which with a very, very short learning curve, this is this is not terribly difficult. So at the end, what we achieve and what we have is a spectral waveform. And this is the typical waveform that we get. We have a systolic peak velocity, which is here. We have an end diastolic velocity, which is here. And we have a mean velocity, a waveform. So what's the point? From the waveform processing, basically the echoes received by the ultrasound, we can actually obtain basic methods and advanced methods. And it's incredible how many information about cerebral hemodynamics we can get and we can achieve from the analysis of the spectral waveform. Generally, the basic methods are the flow velocity, which are basically the systolic, the diastolic, and the mean flow velocity, and then the pulsatility index. We are going to talk about this in a second. And then there are advanced methods. Some of them are actually used in the clinical practice, such as the autoregulation, the non-invasive cerebral perfusion pressure, or the non-invasive intracranial pressure. Some of these methods are actually more used for research, like the critical crossing pressure, the wall tension, and the compliance, or the cerebral vascular time constant. These are advanced methods which are mainly used again for research. We are going to go through them very quickly because they are more engineering more than clinical, but I think it's important to know as well that they exist. So the information which are included in the TCD signal, they depend on which frequency range we analyze. So we have, for example, a low frequency range, which are giving us information about the spasm, hyperemia, autoregulation, and we have high frequency range that we can analyze and will give us information about pulsatility index, critical crossing pressure, non-invasive CPP and ICP, and the cerebral compliance. So let's start from the basic methods. This is the flow velocity, okay? So there are many characteristics that we can assess just having a look at the waveform, which are the velocity, the direction of the flow, the morphology of the wave flow. So the systolic flow velocity is mainly dependent on the cardiac output and on the systemic hemodynamics, and it's not actually strictly dependent on the cerebral hemodynamics. So this is the part of the flow velocity which has the least changes in the clinical practice. But actually the diastolic flow velocity is incredibly important, and it has been used as a relevant parameter which was related to cerebral vascular dynamics in the clinical practice. For example, in pediatric trauma, an end diastolic velocity which was less than 25 centimeters per second was associated with a poor prognosis. And it's very easy to understand, I think, because when the intracranial pressure increases, the first parameter of our waveform, which is impaired, is the diastolic part, and we're going through this in a second. So the pulsatility index is one of the most used and simple indices which are derived from transcranial Doppler. Pulsatility index is basically considered as a mirror of a vessel resistance. Mathematically, this is the formula from which we can assess the pulsatility index, which was invented by Mr. Gosling. It is a TCD derived parameter which is able to provide information about cerebral vascular resistance and changes in the morphology of the TCD waveform resulting from cerebral perfusion pressure changes. So mathematically, we can assess it using these formulas. Peak systolic velocity minus diastolic velocity divided by the mean velocity. The opposite of the pulsatility index is the resistivity index. Why is the pulsatility index that important? So pulsatility index has been widely investigated as a non-invasive estimator of intracranial pressure. Again, this is what I was telling you 1 second ago. So when the intracranial pressure increases, the diastolic flow decreases and the pulsatility index as a consequence can increase. So basically, some authors have demonstrated that ICP and pulsatility index are positively correlated during increases of ICP, and some of them, for example, in this paper from Bellner et al., they demonstrated a very strong correlation coefficient with invasively measured ICP, with a coefficient of correlation of 0.95, which is actually excellent. However, I have to tell you that other authors have found less positive results, and they have found a very weak correlation between pulsatility index and ICP. And the reason is that pulsatility index is strongly influenced by other factors such as the carbon dioxide and hemodynamic factors. By the way, this is the typical behavior of pulsatility index according to the changes of intracranial pressure. If you can see on the left panel, we have ABP in the first row. Then we have ICP, which on the left side has got normal values, okay? And here we have our flow velocity with a systolic peak, diastolic peak. So what happens in the right panel? It happens basically that the intracranial pressure increases here. And as you can see, what is actually impaired is not the systolic component of the waveform, but it is the diastolic form. And as you can see, there is an important and clear change in the shape of the cerebral blood flow waveform during the increases of intracranial pressure. This is another example which is telling us how pulsatility index is a useful index of decreasing CPP. Again, in the first row, we have our intracranial pressure, then we have the CPP, cerebral perfusion pressure, our flow velocity measured through transcranial Doppler, and our pulsatility index. And have a look. Here, for example, there is an increase of intracranial pressure with a concomitant decrease of CPP, and there is a peak on the pulsatility index. And this is what happens here again and again and again and again, okay? So pulsatility index is directly correlated with ICP and inversely correlated with the cerebral perfusion pressure. Let's move on. So and let's start with advanced methods, the autoregulation. Neurointensivists are in love with autoregulation, and we think that autoregulation is so important. This is a very nice drawing from Mr. Githosh, who put this, his daughter made this drawing. She was 7 years old, and he put this drawing in his PhD thesis. So autoregulation is important because it's basically associated with the outcome. To assess the autoregulation, we need something. We need the tool which is able to measure the cerebral blood flow. And transcranial Doppler is a surrogate of cerebral blood flow because the flow velocity is proportionally dependent on the cerebral blood flow. So I believe that all of you know this paper. This is a very old paper, and it's the masterpiece of autoregulation. This is the very famous Laaser curve. So what is this graph telling us? It's telling us that the cerebral blood flow here remains constant despite a reduction of the mean arterial blood pressure. And there is just one point here, which is the lower limit of autoregulation, at which point what happens is that there is a reduction in the cerebral blood flow. This means that our brain is actually very smart because it's able to protect itself despite the changes in arterial blood pressure. But there is a point here where our autoregulation mechanisms are exhausted, and so the CBF basically decreases. And we need to understand in our TBI patients, in our neurocritical care patients, where is this lower limit of autoregulation. And why do we have to know it? We have to know it because basically an impairment of the autoregulation is strictly correlated with a poor outcome. This is a very nice review, which has been written by my colleagues in Cambridge, Joseph Donnelly, who is a great PhD student. And as you can see here, not just in neurocritical care patients like in TBI, subarachnoidal hemorrhage or stroke, but even in patients with sepsis, for example, or preterm infants, an impairment of the autoregulation is able basically to determine a poor outcome in our patients. So how does the transcranial Doppler, how is it able to reproduce the Laaser curve? So basically here, this is a very nice paper from Marek Czosnika. And as you can see, if we plot the flow velocity with the CPP, what we obtain is actually our Laaser curve, where we have at this point the lower limit of autoregulation, and here we have the upper limit of autoregulation. So for example, in this patient, we know that between 60 to 90 millimeters of mercury of CPP, the patient is autoregulating, and that's where we need to keep the patients in our clinical practice. The way the transcranial Doppler is able to determine and to assess the autoregulation It's a method which is based on an input and output signal. This is a very nice example. So here in the left panel, we have, for example, the relationship between ABP and flow velocity. So what happens is that when we have a negative relationship between the ABP and the flow velocity, it means that the patient is actually autoregulating. Why? Because basically when the ABP increases, the flow velocity decreases because we have a vasoconstriction to maintain a constant cerebral blood flow. And this means that the patient is autoregulating. But there are cases, like in the right panel, where when the ABP changes, well, for example, it increases, the flow velocity passively increases, or when the ABP decreases, the flow velocity passively decreases. This means that the two parameters have got a positive correlation, and it means that the patient is not autoregulating. So the relationship between these two parameters has been called MX by the group of Cambridge. And basically from the calculation of the MX, you are able in real time to build our Laaser's curve, where when you have a positive relationship between the two parameters we were talking about a few seconds ago, so here and here, it means that the patient is not autoregulating. When you have a negative value of MX, so when the patient is autoregulating, it means that we are at this point of our Laaser's curve. And this is actually important, and it does actually work because MX, this index of autoregulation, is strictly correlated with the outcome of the patient. And as you can see, when the MX is positive, and I remind you that when it is positive, it's because the patient is not autoregulating. The patient has got an unfavorable outcome. On the opposite, when the index of autoregulation is negative, it means that the patient has got a favorable outcome. I hope it's clear so far. Unfortunately, now we have to start the difficult part, which is not very clinical. It's more engineeristic, but I'm going very fast on this part. So among the advanced parameters, one of the most studied is the critical closing pressure. So the critical closing pressure was first introduced by a neurologist, again, whose name was Barton. And basically it's theoretically described as the sum of ICP and vascular wall tension. Wall tension represents basically the vasomotor tone, which is the determinant of the clinical closing pressure. And clinically, which is the part which is important for us, it means that the critical closing pressure is the lower threshold of ABP, below which small brain vessels collapse and the cerebral blood flow ceases. Okay, so there are a lot of studies about critical closing pressure. Here on the left side, in the upper panel, we can see an infusion study. So basically what we do in Cambridge is, unfortunately, we use animal models, and we use saline, infusion of saline in the CSF. So we do basically a lumbar puncture, and we infuse normal saline, and we basically create a model of acute intracranial hypertension. And in fact, what you can see here is that in this rapid, you have an increase of intracranial pressure. The ABP until a certain point is maintained. The CPP drops. And here is the flow velocity with decreases together with the cerebral perfusion pressure, okay? And here is where there is the critical closing pressure. Another very important and interesting, basically, parameter is the cerebral compliance. So the cerebral compliance is the ability of the brain to adapt to the changes in volume inside the cranium in the response to a change in pressure in order to avoid intracranial hypertension. There are actually two main types of compliance: the cerebral vascular arterial compliance here, and which basically describes the change of arterial blood volume in response to change in arterial pressure. And then there is the compliance of the cerebral spinal space, which is basically called Psi-E. which refers to changes of volume in the intracranial space in regards to changes in ICP. And this last one represents basically the combined compliance of a venous bed and of a CSF space, because the venous compartment is generally considered a part of a CSF compartment. So how do we use the cerebral compliance? It has been actually used by a lot of authors, but most of it has been used for research purpose. It's very difficult, and it's also not very easy to assess the cerebral compliance in the clinical practice, at least in real time. But this is a very nice example that I want to show you. So this is a plateau wave. So I'm sure you all know what a plateau wave is. It's basically an increase of the intracranial pressure which persists for several minutes. And the origin of the plateau waves is determined by the intrinsic cerebral vasodilation with a rise in cerebral blood volume and a rise in ICP. So therefore, according to the very famous vasodilatory cascade hypothesis, these changes are associated with a rapid increase in the arterial cerebral compliance, which is caused by the vasodilation of cerebral resistive vessels during a plateau wave, and the reduction of the other cerebral compliance, so of the venous and CSF cerebral compliance. Why? Because there is a decrease in the cerebrospinal compensatory reserve, which is consequent to an increase in cerebral blood volume. So this is a very nice example, but it's not very easy to see something like this in the clinical practice. The application of this technique is actually a bit limited, but we can actually assess what is the site and the moment of exhaustion of the autoregulatory systems of our patients. So another very important parameter is basically the cerebrovascular time constant. What am I talking about? So the cerebrovascular time constant, which is called C-tau, is basically a non-invasive TCD-based index, which actually indicates the time to establish a change in cerebral blood volume after a sudden change in arterial blood pressure during one's cardiac cycle. So C-tau is basically an analog to time constant, and it's calculated as the product of the brain arterial compliance, and that's the reason why I showed it before the arterial compliance, and the peripheral resistance. And it's something which is actually expressed in time units. So both CA, which is the cerebral compliance, and the CVR, which are the peripheral resistance, are calculated from the relationship between the pulsatile ABP and the transcranial Doppler flow velocities. So why is this parameter so important? So C-tau has been studied in healthy volunteers and in patients with severe stenosis, for example, in the internal carotid artery. As you can see from this graph, basically the C-tau is found to be significantly shorted in severe internal carotid artery stenosis compared to the controls, and it was actually correlated with the degree of stenosis. So it's able actually to tell us that something bad is happening in our cerebral hemodynamics, okay? Before that the patient has got symptoms or any clinical manifestations. And the same has been demonstrated in patients with subarachnoidal hemorrhage, because actually the C-tau has been found to be shortened on the side of aneurysmal subarachnoidal hemorrhage before the developing of vasospasm. So it was actually able to tell us that the patient was going to get worse than from a neurological perspective, which is a very important message. So let's move on. Cerebral perfusion pressure. So it's very important to assess the cerebral perfusion pressure, because basically there are many situations where we don't have an invasive intracranial pressure, but we would like to know what is the value of a cerebral perfusion pressure. So using the transcranial Doppler, there are different methods, basically two main methods, which has been used to assess the CPP in a non-invasive way. The first one is basically a method which was developed by Hazlitt, which is this one. Honestly, I have to tell you that you need a peculiar software to use this formula, and the relationship, except this paper, which I'm showing you here, has never been confirmed from other authors. But actually in 1997, Professor Chodek and Peter Zmielewski, they tried to use another kind of formula. So they tried to assess non-invasively the CPP using the arterial blood pressure, the diastolic flow velocity, and the mean flow velocity, so easily using the transcranial Doppler. And actually they found very, very good relationship between the invasive CPP and the non-invasive CPP. These are the results of their paper. So here you can see the intracranial pressure. So here you can also see the flow velocity and how it develops and changes during the changes of ICP. Here you can see the invasive CPP, and here you can see the non-invasive CPP. And you can see that they actually behave in the same way. And they found actually a correlation between non-invasive CPP and measured CPP, which was very high. It was 0.73. This is another example. Using obviously this formula, you know that from the CPP it's very easy to obtain the ICP values, because you know that ICP is CPP is ABP minus IBP. So basically using this formula, they also found basically a method to assess non-invasively intracranial pressure, but we are going through this in a moment. So let's try to be a bit more practical, okay? So when I say that the transcranial Doppler is a stethoscope for the brain, this is what I mean. So there are a lot of information that we can get from a transcranial Doppler. Some of them are very practical. Some of them, like the critical crossing pressure or the C-tau, are less practical, but I still think they need to be mentioned. But we are doctors, and we need to know how we can apply transcranial Doppler in the clinical practice. So traditionally, the transcranial Doppler has been used in a wide range and variety of conditions for neurocritical care patients. So it's been used for arterial stenosis, for the assessment of vasospasm, arteriovenous malformations, TBI, venous sinus thrombosis, hydrocephalus, embolism, evaluation of cerebral circulatory arrest. So let's start from the main, and probably it's the most used application of transcranial Doppler, which is the vasospasm. I'm not sure if you guys are all neurointensivists, so I'm sorry if I tell you things that you already know. After subarachnoidal hemorrhage, the vasospasm is basically happens basically in the 30% of the patients, and it's related to a narrowing of the main cerebral vessels. So you will understand very easily that the velocity on the middle cerebral arteries and on the other vessels of the Willis circles will be impaired. And what does it happen when you have a narrowing of the vessels? That the velocity increases. So if the normal velocity of the MCA is between 30 to 80 centimeters per second, it will increase during vasospasm. But a lot of authors have also studied that TCD and the velocity on the MCA is actually able to discriminate between mild vasospasm, so when the velocity, the mean velocity is up to 120 centimeters per second, and it means that there is a 25% of narrowing of the vessel. Moderate vasospasm, so when the velocity is between 120 and 200 centimeters per second, and it means that there is a 25 up to 50% of narrowing. And severe vasospasm, when the velocity is higher than 200 centimeters per second. So this is actually a typical waveform that you can see during the vasospasm. Here on the left side, we have our Willis circles, and here we are insonating the MCA. And look at here, we have a flow velocity, which is incredibly high. The systolic peak, it's up to 300. And this is definitely a vasospasm, okay? But we all know that cerebral hemodynamics, and in particular the brain, is never alone. So you can see an increase of the flow velocity of the MCA because you have a vasospasm, but you can also see an increase of the flow velocity of the MCA because the patient might be in a hyperemic state. So Lindengaard, a few years ago, invented this index, which is basically called the Lindengaard index, and it's basically based on the relationship between the mean velocity of the MCA and the mean velocity of the internal carotid artery. And the principle is actually very easy. If you have an hyperemic state, you will have an increase of the flow both on the internal carotid artery and of the MCA. But if you have just a vasospasm, the ICA flow will be normal and the MCA flow will be increased. So when we have a patient and we have a suspicion of vasospasm, what we need to do and what we actually do in our daily practice is to monitor him with a daily TCD. So if we find a flow velocity which is below 120 centimeters per second, we're pretty sure that the patient is not developing a vasospasm. But if we have a patient whose flow velocity on the MCA is above 200 centimeters per second, we are pretty sure that the patient is actually developing and having a vasospasm. And then there are borderline cases when we see velocities which are between 120 and 200 centimeters per second. And so what we need to do is to apply the Lindengaard index. So if the Lindengaard index is below 3, the probability of vasospasm is very low. Between 3 and 6, we have an intermediate probability, and if the Lindengaard index is above 6, it means that we have a high probability of vasospasm. So let's move on and let's see another very important application of transcranial Doppler in the clinical practice, which is actually the non-invasive ICP. So this is the normal waveform, and this is what happens when the intracranial pressures increases. So initially we have just a reduction in the diastolic velocity, and when ICP approaches the diastolic pressures at the level of the microcirculation, the end diastolic velocity is basically 0. And this is what happens in the context of brain death. So when the intracranial pressure is so high that the CPP is basically 0. And what we can see here is a reversal of the flow during the diastolic phase. So again, the transcranial Doppler has been widely used and started for the assessment of the intracranial pressure. And the pulsatility index has been one of the most used parameters to assess intracranial pressure. As I was telling you 1 second ago, basically it's not the best way to assess intracranial pressure because most of the authors found weak relationship between the pulsatility index and intracranial pressure. But on the other hand, the method that I was mentioning you before, which is here, which was the method which was initially invented for the assessment of the CPP, has actually given very, very strong relationship with the intracranial pressure. And this method, I'll tell you in advance, has been used from the group of Brescia to develop a multi-center study which is going on. There are something like 20 centers involved, and from the preliminary results, what we found is that this method is actually able to discriminate intracranial hypertension in the 99% of our patients. So in the clinical practice, I think that this is a very, very important method. And this method has been studied, and we did this experimental study, which was on rabbits. We studied 95 rabbits, and here we compare different transcranial Doppler methods. So the pulsatility index, the method which was based on Hazlitt formula here on the left, and the method which was developed by Chosnik et al. And again, we found that the method by Chosnik et al. Was the best one to assess non-invasively the intracranial pressure. This is a very nice review from Dr. Kardim, who is another great collaborator from our laboratory. And again, this is a very nice review, which basically includes all the different methods which are basically TCD based and which are basically used to assess non-invasively the intracranial pressure. The results at the end of the story are that transcranial Doppler cannot substitute the invasive intracranial pressure, but there are a lot of situations and conditions where intracranial pressure in the invasive monitoring is not available or it's even contraindicated. Just think about the patient with coagulopathy, patients with liver failure, patients who are anticoagulants, and you cannot put an intracranial pressure monitoring. In these cases, the transcranial Doppler is actually very, very useful, not only to assess, but to exclude patients who are developing intracranial pressure. So basically, we are not aiming for a number, because I personally don't really mind if a patient has got 11 or 12 of intracranial pressure. I basically don't care from a clinical perspective, but I want to know if a patient has an intracranial pressure which is higher than 20 millimeters of mercury, and so he is at risk of complication or not. So other TCD applications, cerebral circulatory arrest. So I'm not sure how it works in Mexico. In the United Kingdom, the diagnosis of brain death is just clinical. But for example, in Italy, where I come from, to assess and to make a diagnosis of brain stem death, we need an instrumental method. And one of these methods is the transcranial Doppler, and it's actually an official method to assess the absence of cerebral blood flow. So you don't have to think that when you do a transcranial Doppler to assess and to make the diagnosis of brain death, you will never see anything, because there are some flows which are actually compatible with brain death. So the oscillating flow or the systolic spikes are both signs of cerebral circulatory arrest. The systolic flow is actually nearly similar to the reversal of flow in diastole, which we have seen a few slides before. And the systolic spikes is basically very short velocity peaks, which are seen just during the systolic. And that the reason why we can see them is because the patient has got still a heart which is beating. These are actually two examples. This is the reversal flow. So the systolic component is actually preserved, but it has got this shape, and then you have a flow reversal here. And here you have your systolic peak. And these signs are compatible with cerebral circulatory arrest. So it's important to mention that the transcranial Doppler and the application of the transcranial Doppler are not just for neurocritical care, because if you think about all the possible information that we can have about the brain just using an ultrasound, you will actually probably agree with me that there are several conditions and several environments where we would like to know what is happening in the brain of our patients. For example, in the intraoperative settings, there are some kinds of operation which put the patient at risk of intracranial hypertension, metabolic coma, septic shock, and also in pediatric and pregnant population, the use of the ultrasound to assess cerebral dynamics would be really, really important. When I talk about the operating room and situation which can put the patients at risk of intracranial hypertension, this is actually what I mean. We did a couple of studies about this. You probably all know that prone position and changes in positive and expiratory pressure can increase the intracranial pressure. So we did this pilot study a few years ago in patients undergoing spinal surgery. So the patients were put prone, and we changed the PEEP basically from 0 to 5 up to 8 centimeters of water. So what we saw is that all these methods, TCD-based, but also the optic nerve sheath diameter, which is another ultrasound-based method to assess non-invasively ICP, they actually detected an increase of intracranial pressure after the prone position and the use of the PEEP. But there are a lot of conditions in the operating room, which again put the patient at risk of increased intracranial hypertension. For example, when we use the pneumoperitoneum and the Trendelenburg position, we actually determined an increase of intracranial pressure because we have an increase of the CO2, because we have a compression of vena cava, for many, many reasons. And again, what we found in this paper and in this study, which was published on BJA last year, is that the 7% of the patients without any neurological conditions, previous neurological condition, who undergo pneumoperitoneal and Trendelenburg position experience an increased intracranial pressure. In general ICU, I think that general ICU is the main application of this method. This is a very interesting paper which basically explores the use of transcranial Doppler in sepsis. So we all know that some of our patients develop a septic encephalopathies, or they develop neurological complications after septic shock. And there is not actually a real explanation. So what the authors found here is that in patients with septic shock, there is a cerebral vasoconstriction, so there is an increase of the flow velocity which was detected by transcranial Doppler. And actually, the autoregulation was strongly impaired. So probably the MAP target that we normally use for septic patients and the threshold of 65 millimeters of mercury that we aim to achieve in septic patients is not the same, and it's not right for all the patients. So I think I've talked even too much. I come to my conclusions. I strongly believe that the transcranial Doppler is actually a stethoscope for the brain. We can get really a lot of information about cerebral hemodynamics, which include simply the mean flow velocities, the development of spasm of hyperemia, cerebral autoregulation, but also cerebral critical causing pressure, the compliance of the brain. But additionally, what is most important, and what is most important both for the clinical practice but even for the research setting, is the estimation of the CPP and especially of the intracranial pressure. So I thank you very much for inviting me to this webinar. I have to thank my group, which are with the Brain Physics Lab in Cambridge, Dr. Smielewski, Dr. Sofia Czosnika, our PhD students, my clinical team, which is a wonderful group of people, which are led by David Menon, Harun Gupta, Peter Hutchinson, Andrea Lavinio, Basil Matta. But most of all, I would like to thank Professor Marek Czosnika, who has been my PhD supervisor and is a great person. And I give you his hello, because he knew that I was giving this talk. So hello from all of us. Thank you.
Thank you so much, Chiara. It's amazing. It's fantastic, your talk. Thank you very much, Chiara. There are some questions from the audience. I'm going to speak in Spanish for a while. Víctor Pérez preguntó si podría explicar nuevamente la diapositiva con el flujograma donde se ve el diagnóstico de vasoespasmo. Could you explain again the slide with the fluxogram vasospasm diagnosis, please?
Here?
Yes.
So what's the question? I'm sorry.
Okay, the question is, only explain again that slide, Chiara. They want to know in detail the flujogram.
Yes. So basically, when you have a vasospasm, it means that there is a sort of stenosis. So the artery is restricted. So the flow after this vasospasm is basically increased, okay? So if the normal value, for example, of the MCA are 30 to 80 centimeters per second, if you have a vasospasm, you will see an increased flow. Here, as you can see, the systolic peak is nearly 300, okay? And the mean velocity is around 200, which is basically crazy, okay? So probably what was not very clear is the Lindegaard index. So we are actually doing a brain ultrasound of the brain. And what we are seeing is an increased flow velocity. So I don't actually know if the increase of the flow velocity is due to a real vasospasm or if it's due, for example, to an hyperemic state of my patients, okay? So in many situations, so many patients in ICU are in a hyperemic state, okay? So how can I differentiate these two situations, vasospasm and hyperemic state? Using this index, because if you have basically an hyperemic state, you will have an increased flow in the MCA for sure, so in the brain circulation, but also in the systemic circulation, so in the internal carotid, okay? That is that clear? So if they are both increased, the Lindergan index here will be low. But if I have a vasospasm, the flow in the ICA will be normal and the flow in the MCA will be increased. So the Lindergan index will be very high with this threshold, which has been studied by the literature, okay? So this is the way to discriminate these two situations. Hello?
Okay, very, very good. Very good, Chiara. Thank you so much. It was very clear. Whether there is someone questioning about the transducer you use in transcranial Doppler, Chiara, could you please explain a little bit more about the different types or different kinds of transducer you use in order to perform the transcranial?
You actually use a 2 megahertz probe, which is the probe that you use for the cardiac ultrasound. So nowadays, most of the ultrasound machines have got a peculiar settings, which is called transcranial Doppler, and which optimize the image of the brain. So when I was telling you that there are actually two ways to do transcranial Doppler, is because one way, which is the simplest one, is just to use the cardiac probe. So this picture, for example, this video, which I think is very nice. So it's a video which was taken from a patient here. There is obviously the probe from the temporal window. So basically from here, okay? So what you can see here, this is the mesencephalus, okay? And this is the Willis circle. And this is the anatomical representation of the Willis circle. So this is the first option. So you use the 2 megahertz probe, you put it in the temporal window, you put the power color Doppler, and you can actually see the vessels. But traditionally, especially well, now things are changed, but this is a nice example. There was the blind transcranial Doppler. So this was just a probe, a 2 megahertz probe, but it was not an echo duplex ultrasound. So you are not able actually to see the brain anatomy. You are not able to see the vessels, but with the M mode, you are able to insonate the vessels, and according to the different characteristic of the vessels, you are able to differentiate them, okay? So I think that this is how I have learned, okay, because I'm old, but I think that nowadays, basically, what I would suggest to do is to use the ultrasound because it's actually much easier and it gives you less chance of mistake, okay?
Thank you, Chiara. Well, I have a question for you, Chiara. You talked about the usefulness of transcranial Doppler in patients with sepsis. I think there are a lot of people interested in that topic because we are intensivists and we see patients with sepsis every day, you know? So we would like to know from the practice point of view, what is really the usefulness of the transcranial Doppler? I mean, are you searching for a target for a specific number of flow, or what is the usefulness in patients with septic shock?
So I think that most important clinical application is to assess the intracranial pressure non-invasively, because actually we actually don't really know what happens in the brain of a patient with septic shock, and we keep them sedated, then we wake them up and they have neurological complications, and you say, why? I mean, I followed the Surviving Sepsis campaign guidelines. I've kept my patients at 65 millimeters of mercury of MAP. What did I do wrong? But these targets are just about the septic status of a patient, but we don't know what's happening in the brain of a patient. So I'll give you an example. So sometimes in patients with septic shock, I use transcranial Doppler to assess the autoregulation. And as you have seen in my previous slides, transcranial Doppler is actually able to tell us what are the threshold, the lower and the upper limits of autoregulation. So it's telling me basically where the patient is autoregulating best. So I'll give you an example. If I have a patient whose cerebral autoregulation is between 70 to 80 millimeters of mercury, I will probably aim to achieve a map of which allows me to have a CPP of 70, 80 millimeters of mercury. So it's the map target that is probably the most important part that needs to be taken in consideration.
Okay, thank you, Chiara. Well, I don't know if there is there are more questions, but I would like maybe the last question for you. I know you are tired, Chiara.
I'm not.
Could you please talk about the use of transcranial Doppler immediately after the cardiac arrest? Because we don't know if we will see in patients with cardiac arrest maybe we will see a cerebral flow pattern of brain death, or I don't know what your experience is about this topic specifically.
So I really hope that after cardiac arrest, at least immediately I am able to see a flow. So if I don't see a flow, basically the role of a transcranial Doppler is diagnostic. So just to certificate brain death. But let's be positive and let's think that our patient survives, okay? And you have a patient whose brain is probably going to get swollen because he had a moment of hypoperfusion. So the question is, what are we going to do? What's the MAP target? What's the CPP of the patient? What's the intracranial pressure of the patient? Is his brain really getting swollen or not? And in my experience, for example, there are not neurosurgeons who will never put an ICP bolt in a patient who had a cardiac arrest, okay? And it's completely out from the guidelines, honestly. So that's why we use the non-invasive methods. So for example, immediately after the cardiac arrest, we measure transcranial Doppler. So we assess the non-invasive CPP and the non-invasive ICP. So if we see that the patient has got a low CPP and the high ICP, what we do is we increase the noradrenaline, we increase the inotropes, or we use fluids according to the clinical situation of the patient. We can use sometimes hypertonic saline to reduce the intracranial pressure, okay? And we use the non-invasive methods as targets from our therapy in terms of brain protection. Because otherwise, the other signs that we have are clinical signs, which are very tardive. So when we see a patient with bilateral unreactive pupils, it's too late. The brain is already very swollen.
Okay, quite interesting, Chiara. And maybe the last one, Chiara, please. Sorry. I have a last question. You mentioned also about patients with ARDS. This is a very hot topic in
yes.
Okay.
So we are actually running a study in patients with ARDS. And what we are going to do is to assess the cerebral hemodynamics using the TCD during the PEEP changes, during the recruitment maneuvers, and during the prone position. Again, you know that ventilations in ARDS and TBI are not friends. So recruitment maneuvers, PEEP, prone position, they are all conditions which can increase intracranial pressure, okay? So if you have a brain injured patient, you actually don't know what you're doing. You recruit him, you increase the intrathoracic pressure, and there is a high risk of cerebral complication. So we monitor our patient with brain ultrasound to perform safely the respiratory maneuvers, basically.
Okay, thank you, Chiara. It was very clear. So, Chiara, thank you so much again. I'm going to finish the webinar. Please stay there. I'm going to speak in Spanish only.
Okay.
Okay, gracias a todos. Con esto vamos a terminar nuestro webinario. Les invitamos también a participar en los próximos que van a estar muy interesantes. Y asimismo los invitamos a nuestros cursos de ultrasonido pulmonar que se van a llevar a cabo con el doctor Giovanni Volpicelli ya próximamente. Ojalá se puedan inscribir, no desaprovechen esta oportunidad. Les agradecemos mucho y pues si ya no hay más preguntas, gracias por participar, chicos, y nos estaremos saludando muy pronto. Gracias por todo. Okay, Chiara, thank you so much. I really appreciate your attention. Thank you for accepting. This was amazing talk. There are a lot of people interested. Maybe we will talk later about the certification. I think there are a lot of people interested in certification here in Mexico. Hopefully, we can to speak later about certification.
Yeah, let's keep in touch. Absolutely.
Okay. Okay. Thank you, Chiara, and thank you again. And please, don't lose the contact with us. I appreciate all your attention, and thank you so much, Chiara. I am going to finish the meeting. Okay.
Thank you again. It's been a pleasure to meet you, and I'll talk to you soon.
Thank you. See you soon.